Yes, good afternoon, ladies and gentlemen. My name is Caesar Msamba. So before we start, I would like to, for those people who are sitting behind, maybe you can cover the seat here so that those people who are coming after us, they can sit there. Dr. Elise and the others, please, let's fill these seats over here. Thank you so much. Please, let's fill these seats here as well, in front of us. Thank you so much. Welcome everyone to this forum where we are going to share the experience and best practice for effectively reaching men with HIV prevention services and explore innovative strategy to improve outreach and increase awareness of HIV prevention among men. And you know the theme of this year is joining effort for quality healthcare through private-public partners. So I would like to introduce and welcome the panelists, starting with NASHCOP presenter. Dr. Wenda. A round of applause to Dr. Wenda. I would like to call upon Dr. Margaret. Dr. Margaret is a public health specialist. Please, you're welcome. We'll be followed by Dr. George Loy. Round of applause to Dr. George Loy. We have Mr. Bernard Ogwang. You're all welcome. And the last but not the least, Mr. Edie Swedi, who is our peer. You're welcome. A round of applause, please. This session will be taking like 1 hour and a half, and communication should not be the barrier. So we are free to speak any kind of language, but we are encourage a lot of questions after. Kwa hiyo Kiswahili na Kiingereza vinaruhusiwa. Cha muhimu tuweze kufikia kile ambacho tunakihitaji. Kabla hatujaanza forum yetu, tutakuwa tuna panelists kama tunavyowaona ambao tutaupata wasifu wao hivi punde, na baada ya kupata wasifu wao tutakuwa tuna discussion au wasilisho kwa kila mmoja wao, ambapo litahusisha maswali na majawabu kwa dakika 10 kwa kila presenter. Then baada ya hapo tutakuwa tuna maswali na majibu kutoka kwenye members of the floor. Starting with Dr. Wenda from NASHCOP, I would like to take this opportunity to give you this privilege for you to stand and introduce yourself. Give us your bio, and then we can proceed. Thank you.
Thank you. Good afternoon. It's my pleasure to be given this opportunity to represent NASHCOP. And for those who don't know, NASHCOP stands for National AIDS, STIs, and Hepatitis Control Program, which is a technical arm of the Ministry of Health in those 3 diseases. My name is Wenda Maokola. I'm serving as a lead in the unit of epidemiology within NASHCOP. And I'm a medical doctor with MSc in tropical infectious diseases and epidemiology in infectious disease epidemiology. And for quite a long time, I've been working in HIV and TB research, but now I've broadened my scope to include routine monitoring and evaluation, which is my current position within NASHCOP. I think that is it. Thank you very much.
Thank you so much. A round of applause. Makofi hajatosha. Asante sana. Dr. Wenda, we would like to know overall situation among men and intervention in places, highlighting what has been done by the Ministry of Health, way forward, as well as First 95 for men versus women in our country, but the health-seeking behavior of men versus women in Tanzania that can be compared across region.
Thank you very much. First of all, I think we all know that as a country we have adopted UNAIDS 95/95, and as alluded by the moderator, first the 95 refers to HIV identification, is the proportion of those who have been identified with HIV among those who are estimated to have HIV. So that's what first 95 is. And statistically, although in our routine data, even the population surveys, we know that women are more affected than men in HIV infection. But in terms of health-seeking behavior and other parameters, men are lagging behind despite the fact that they are not as infected as women. For example, during the last survey, which was done in 2022, the famous Tanzania HIV Impact Survey in 2022-2023, if you compare it with the previous survey, which was done in 2016, overall we see an increase in the first 95. Our identification improved if you compare those two surveys, but it is more improved with women compared to men. So for men, the change is they moved from 52% in 2017 to 78% in 2022, versus women who moved from 65 to 85 in terms of first 95. So we see men are still lagging behind in the identification that we have them. We have people who are estimated to have HIV, but we are not identifying. So this is, as spoken by the moderator, is one of the topics this afternoon whereby we will brainstorm on what we can do around that issue. But as I said, men are having poor health-seeking behavior, and they actually have a higher risk compared to women. I can cite some examples. For example, in social cultural norms, we all know that men actually take time to seek services, and this has the roots back into the culture that probably admitting that I'm sick is equals to weakness. So you'll find that this doesn't even apply to HIV alone, but even in other diseases, men take time to consult health services. So we see that they go to hospitals or other providing facilities while it's too late, and sometimes they don't go at all if you compare with man, but with women, sorry. But also they have increased the risk behaviors. Our surveys tell us that risk factors which expose men to HIV infection include multiple sexual partners. This is from our surveys. They ask men, how many women do you have? And if you compare with what women say in that set of research with all the biases we have, this is what we know, that men have this kind of risk. But the other thing is, still from our data, is condom use. If you compare men and women in terms of condom use, men tend not to use condoms rather than what women do. But there is also another risk, which is alcohol or drug use. Statistically, more men use alcohol and drugs compared to women. But there is another risk, which has something to do with the occupation. I think you all know what we mean by other vulnerable populations. And if you look at the categories for our country, we categorize populations such as truck drivers, miners, and migrant workers, like those who are working in the construction industry, as other vulnerable populations. And this have increased risk of HIV compared to other people. But we find that most men are the ones who are involved in these activities, so expose men more into these risks, although they don't seek medical attention. But the other thing which I touched a bit is in gaps in health-seeking behavior. So if you look into HIV interventions, for example, testing. In testing, our data shows that the uptake, if you compare men and women, we have low uptake among men compared to women. Even linkage to HIV care and treatment, if you compare men and women, we have low scores for men. And the other, which is HIV struggling with viral suppression, is men. So in general, just to sum up to what I've just talked, one, women are more infected than men, but we are struggling in identifying men, that is first 95. But we are also striving to get these people who are, the few men who are testing, to link them into care, but also to have them have HIV viral load suppression. And we have all these factors which expose men into HIV risks, and definitely with the other STIs. So with this, I would like to end my conversation and back to you, moderator. Thank you.
A round of applause, please. Thank you so much, Dr. Wenda. Tunashukuru kwa effort hizo ambazo zimekuwa zikifanyika, lakini kama wizara tunaamini kuna mambo kadha wa kadha ambayo yamefanyika. Tungependa kujua some highlights on what have been done by the Ministry of Health, and if you can tell us the way forward as per what you've been saying.
Thank you. I think most of the interventions will be expanded, colleague from THS, but just in a nutshell, with the HIV prevention, generally, we do categorize into three. So we have biometric interventions, we have structural, and we have other types of biomedical. So in structural interventions, mostly we have, what we have done for men is to encourage here and there to improve the economical status. So we know that HIV, one of the risk factors is the economic situation of the people. So we do have interventions to improve socio-economical situation or status of the people. But we also have, in terms of structural, we do, when we do HIV testing, we definitely do counseling. So we also want them to change their behaviors. So if one comes, even if it turns up to be negative, we do counseling and on social behavioral changes. But for those who are using drugs, for example, we do what we call harm reduction. So it's a whole battery of behavior changes around using drugs and such risks, which keeping people at a risk of acquiring HIV. But we also do have biomedical interventions, just to mention a few. We have condom programming for men. We do encourage PrEP for those who are eligible to have PrEP, but we also encourage to have testing, although we know that men are not that much testing as women. So around testing, we do some innovations around men into testing, such as eating and partner testing, and we also have other interventions which expose men into HIV testing, like VMMC. So this is also another way of getting more men into testing. But we know that we also have ART for prevention. So we actually, after testing, we encourage men to be linked into HIV care. And we also know that if we concentrate on HIV care and treatment and achieve undetectable HIV viral load, we go into U is equal to U, and then we cut the HIV transmission. So all these are around helping men in protection, as well as knowing their status to be linked into HIV care, but also to help them live, if they are found to be positive, to live a quality life by adhering to HIV care and treatment. So just to sum up to what I've said, this is all from our integrated strategic plan, which is 2022-2026. And in that strategic plan, we insist on population or people-centered approaches. So we have actually, for each population, women, men, and other populations, we have targeted the interventions, because this is no more, as we are going into HIV epidemic control 2030, this is not a time where we have interventions which fit for all people. So we have actually used the data and all the information we have to try to focus on everyone's needs. So this is what we call equity. So we don't just implement interventions all by the same fashion. So we actually depend on some parameters, we deliver these services. Thank you very much, and back to you.
Thank you so much. Makofi tafadhali. Najua tutakuwa tuna maswali mawili matatu, kwa hiyo nitaomba tuwe tuna note down, alafu baada ya panelists wote kumaliza, basi tutapeana muda kwa ajili ya kuwa na maswali na majibu. Asante sana from Dr. Wenda. Sasa tutakuja kumsikia Dr. Margaret. Dr. Margaret yeye ni public health specialist. Naomba mplay ile bio yake. Dr. Margaret is the public health specialist as well as a lead KP Youth and FHI program in Tanzania. Communication for AIDS. Dr. Kageshi is a medical doctor with over 10 years of experience in the management of healthy services from the districts to the national level, and HIV AIDS prevention and care and treatment services programming for key and vulnerable population. So Dr. Margaret ni moja ya madaktari wenye uzoefu, wataalam na wakongwe kwenye masuala ya afya, kuanzia kwenye ngazi ya wilaya mpaka ngazi ya kitaifa. Makofi kwake tafadhali. Dr. Margaret, welcome to our forum. From you, I'd like to know what has been done in reaching men with prevention interventions, as well as how does the government collaborate with private sector to enhance HIV services, and what are the different sectors' collaboration to improve outcome for men. You're welcome.
Thank you so much. Just to highlight, a lot has been done. I'm from the Tanzanian Commission for AIDS, and probably whatever I may say is from the ministry. We are coordinating all the interventions around HIV. That is our role. So a lot has been done targeting men, and because some of you has been implementing from the lower level. So I can highlight the bigger ones which we have as an initiative as a country, which includes everyone in here. If you remember, some back years ago, we had this campaign called Furaha Yangu. That Furaha Yangu campaign was targeting men, testing. And if you recall, the Prime Minister was a champion for that. All that was an initiative to get a man to get services. So that campaign, we have gone through with that campaign for quite some time. We have been innovating around that campaign in different names and different approaches, but that one was done to access the HIV SRH services. That is one big campaign we all know. In testing services, as Dr. Wena said, we have done a lot as a country, or as a country in terms of VMMC, voluntary male circumcisions. We are targeting men. We are not only circumcising, but we are looking other integrated services, all that targeting men to make sure they are achieving other services. So when you do the VMMCs, not only targeting the VMMC, but also the HIV testing services and other HIV prevention methods. Now we include PrEP, condom programming. We all link that to men. So we know some region, we started with very few regions. We started with 10, then we came to 14, 17, and now we roll out as a country because the other regions were not requiring that. So when you look on the PMTCT services, we are looking at the male engagement, couple testing, all that we are targeting men. Because how you reach them, we know culturally, or I don't know how do I call it, is it culturally? Because if you are telling your wife, go and test, your result will be my results. So all that, so that campaign of let's male engagement, let's have the couple testing. All that is actually we're looking at where is this man? How can we get them? At what time? Who are they? Where are they geographically? So locating those, you make an intervention to targeting all those questions. So another thing which I can recall, now we have peer-led, as ED-SUD was introduced, because sometimes we may not think we understand their situation the way we used to address more adolescent girls and young women and women because they are more affected. According to our data now, it looks like men now are more affected. Where are we? So everyone is waking up with all that. So how we approaching men? Now, everyone is putting an intervention around, including male-friendly services. Now you can go to the facility, you find there is male corner, male peers, they are there. They are searching for other male to come to the services. All that's are efforts, and they're strategically put in place with everyone, each and every one of us. So that I can highlight, which has been we have actually workplaces programs. So in workplaces program is a big thing, because before you implement workplace program, you need to think, is it informal or formal? If it's informal, when do they meet? Where exactly? At what time? All that should be actually factored in whenever we put this workplace intervention. And we have the strategies for workplaces intervention in different sectors, in mining, in fishing. So all that interventions addressing the question you asked me, what has been done? A lot has been done. the question remains, is it enough? If is it enough, why we are not there yet? Why are they lagging behind in every in services? In 1995 was the Minister of Health presented. So we still have questions, but a lot also has been done to make sure we are trying to make sure men are on board with us. So even not pulling us in the 1995. So going back to how is the government collaborating with the private sector, the private sector partnership is a big word. It may not be easy, but let me start with the condom programming. Condom programming, we have something called total market approach. It's divided in 3. So the total market approach is social, public, and private. So we make sure we engage the private team to make sure condoms are being sold in a price where people can afford. So we know we are different in here. So I can give an example. Probably this team here may not buy a 500 condom, 500 shilling condom or 1,000, but someone need for 500, someone need for, there's even 15,000 per condom, 20,000, depending on who you are serving with. So they are there on board. We have them in our technical meeting subcommittee, making sure how are we pushing the condom, the private sector condom, because now we are talking about sustainability. If we don't include them now, we are doomed to fail, because we may not have the public condom for a long time from now. So we need people to know they can buy for themselves, because that is the service they need. And most of the condom in Tanzania is actually male condom. We know we are struggling with a female condom. So male condom, we want them to buy for themselves. If he can buy chips for that lady, why don't he can't buy for 500? That's the discussion and risk perception as we continue to the behavioral change towards men. So also how the private partnership in terms of, let's take on HIV self-test. According to the law of this country, HIV self-test can be sold. You can buy to the shop, to the farmers. It's allowed. That is according to the law. So it may have some critical issues and all that policies, but according to the law, HIV self-test can be bought to that is one of addressing, because most men, especially working men, they don't believe on most of the time of the free stuff. Looks like cheap and it doesn't fit there. So we target everyone. For those who can get the free one, can get free one, but for those who can buy the HIV self-test, can buy it. So we're still struggling with all the approval and everything, but according to the law and regulations which was signed, HIV self-test can be sold to the farmers. Also, workplaces programs, because we know not every workplace is government. We have workplaces which actually, most of workplaces, they are private. So make sure we engage them, the agenda of HIV and what is required according to the HIV Prevention Act. And to provide education is one of the requirements. And that is what we engaged with them, make sure their people get service, their people get knowledge. And that is part of the private partnership, because those people, they need those services, though we are private. If you need those services like getting the testing, you can get from the nearby facility, and it's free. And we know we have this corporate social responsibility. For example, I can provide a GGM, what GGM does, the gold getter mining in the community. They provide service, they provide, they contribute in the ATF. All that is making sure the private people are on board, they are not left behind. Probably that is I can respond in terms of how the government collaborates with the private sectors to ensure the HIV response in different sectors. My last question was, I think that was the last one. So the last was the how different sectors collaborate to improve the HIV outcome for men.
Yes.
Okay. So when we talk about different sectors, my first question was, before you put your intervention on men, you need to ask yourself which men, which age category, geographically, where are they, what do they do? Do they have informal or formal sectors? So now, how we collaborate, we collaborate in a different way. One, we have interministerial. So Minister of Health cannot stand and finish HIV, or Prime Minister's office and Tanzania Commission for AIDS. We need Minister of we need Minister of different ministry. We need Minister of Agriculture, because we have people on plantation. We have men on plantation there, big plantations. Who is reaching them? We need them on board. We have mining. So we need Minister of Mining. All those we have strategies, and we have a collaborative agreement toward those, the interministerial, how we should approach in terms of on HIV response. But we have community and religious. We do have the technical meeting with community religious people, the interfaces. Because we know people go to church, we know people go to mosque, either you like or not, msikitini utaenda. So we expect them now at least to provide those education during the importance of HIV testing, SRH, and many to test, couple testing, because without engaging them, they have people, either you like it or you don't. So collaboration with religious leaders is the most critical part we are addressing in terms of reaching men and other population. And also now we have traditional leaders. The HIV is not only in town and somewhere. There are traditional leaders there. We went in Shinyanga to identify how men are affected, their cultural norms and everything. And these traditional leaders can help us, because they have different culture. In Shinyanga we went, it was like they have something like, I cut you in blood, that blood I need to share with the other one and the other one, because this is our community with the same sharp tool. And now, have they tested? No. Who is reaching them? So now we are starting to reach traditional leaders, and we have a strategy on board now. Actually, it's not a really strategy, guide how we reach traditional leaders. And our first encounter with traditional leader with the young people, it was last year when we were in the Witness Day, listening to them and their negativity, and how we can incorporate what they had for years to be more efficient and make sure they are being prevented from HIV. Also, we have this private.
Asante sana. Asante sana daktari. Round of applause tafadhali. Asante sana. Dr. Margaret, nimefurahi kwa vile ambavyo umetoa wasilisho lako, na moja ya vitu ambavyo ni barriers, na nafikiri kuna wanaume wenzangu hapa watakubali kimoyomoyo, lile swala la kapime wewe majibu yako ni ya kwangu. I think we have been practicing this for a very long time, and tutakuwa na nafasi ya kuangalia kwa vipi tunaweza tukatoka hapo, lakini pia umeweza kupose swali moja zuri sana ambalo nafikiri tutaiweka kama point of discussion to all of the members here, ulipokuwa ukisema kwamba we have been doing a lot for a very long time, na hapa tulipo, je, what should we do from here moving forward? So nafikiri kama tunazo michango yoyote na nini tunaweza tukaziweka kwenye muda wa discussion, itakuwa ni muda mzuri sana wa kuweza kuitafakari hiyo. Asante sana Dr. Margaret. We have Dr. George Roy here with us. Dr. George has over 20 years of experience in the healthy and social sector specializing in HIV, AIDS, TB, STI, and sexual and reproductive health rights. He has held leadership roles in program design and implementation, mobilized resources for global fund and PEPFAR initiatives, and is currently a program advisor with UNAIDS Tanzania, focusing on inclusive, equitable, and evidence-based approach. Makofi kwa Dr. George Roy. Dr. George, kwako tungependa kufahamu mambo machache yenye umuhimu. First of all, we'd like to know the situation among men and intervention in places overall. And then if you can highlight what has been done for men and the role of UNAIDS. Apart from that, we'd like to know the global sub-Saharan Tanzania strategies for reaching men in UNAIDS perspective, role of UNAIDS in reaching men, and the effort to complement Minister of Health work in reaching men with prevention packages and HTS. Karibu, Dr. Roy.
Asante sana. Good afternoon, everyone. I hope you can hear me clearly. Principle is from the UN system. As most of you are aware, UNAIDS is actually a secretariat for the UN system to coordinate HIV-related efforts globally, including in our country, Tanzania. And really thanks for the question, and really it's a follow-up to, my contributions be a follow-up to what Dr. Wena and my sister Margaret have already really given a picture of what's happening in Tanzania. Looking at other countries, particularly in this region, the eastern and southern part of Africa, where our country is based, the picture looks more or less the same, really, when it comes to the HIV epidemic, because it's the HIV epidemic that shows the gap that we are seeing in the HIV response among men. And the evidence that have been collected so far, including really evidence that has come from our country, from Tanzania, indicates exactly the picture that Wena and Margaret have painted earlier. That when it comes to the progress of the HIV response, there are certain population groups that for some structural reasons, some social norms reasons, some behavioral reasons, and some work-related reasons are somehow left behind in the response. And men in particular have been a key population group that it seems to be lagging behind when it comes to the HIV response progress and success. And again, going back to what when I had said, men HIV issue is beyond HIV. Is also an important thing to highlight when it comes to overall health of men, including their well-being. And we all know how important the health of men is for the whole family. And this is the evidence that has come across most of the countries in East, Central Africa, that it's painting the same picture. Now, all of this, at the end of the day, it puts men at a place whereby their tendency to seek services, health, social, and HIV related, is low. And therefore, they put themselves at a higher risk. More important to add into what is being seen across many countries is that because of Well, I'm not going to point this as if it's a competition, but it looks like structure-wise, men have less entry points to access health and therefore HIV services compared to the other gender. I just want to put it clear. Because of the progress that we make, for somehow, there are very few entry points that target men to access HIV and health services, and so other social services as well, which could provide opportunity for them to uptake HIV testing and treatment and support services. This has been a picture that has been clearly shown in many countries. As a result of that, what we are seeing now is that UN system and all its partners, the bilateral and other multilateral partners, have been really taking a lot of efforts into helping partners, stakeholders, and countries in general to do more to create enabling environment for men to be encouraged and motivated to seek overall health, HIV, and other social support services. We know there are a number of social support services that are available which could benefit men in terms of shaping their behavior towards HIV risk and towards their tendency to seek HIV services, as is the issue here in our discussion. And therefore, what I would want to also share with us is that UNAIDS has been working with many partners to encourage countries to implement men-specific initiatives alongside those really successful initiatives that are focusing women, empowering women, and adolescent girls. This should be seen as an approach that will actually complement the gains that are being achieved through those initiatives that are targeting women and adolescent girls. When we include men in this initiative, they kind of synergistic effect in terms of complementing the impact, because the health of the family, the health of the women, and the health of the men, they are all intertwined, they are very much dependent. So this is what countries are now coming up with programs, with initiatives that try to bring men alongside programs that are intending to empower women and adolescent girls in terms of being safe, remaining safe within the context of the HIV epidemic. And therefore, among the many factors that have been considered is actually to consider how to promote positive masculinity. Because one of the key issues that have been found as being really affecting the HIV progress in men is the harmful masculinity. The way men see themselves in place of the societies, in place of their families, and in the place of their children. There are certain social norms that put them as risky, and there are those ones which really solidifies them as important part of the family. And therefore, countries, including our country here, are being encouraged and supported to promote those masculinity issues that are really constructive, and dismantle those ones which are harmful to the family and to the communities. And along the same way then, UNAIDS with partners, PEPFAR, the Global Fund, and other multilateral partners that are, most of them are actually available, present in Tanzania, have developed some call to action frameworks that are meant to accelerate the efforts that are ongoing to bring men HIV response on board. And since 2022, we are already seeing progress, particularly in many countries in the southern point of this continent. Progress is more advanced compared to countries along the Eastern Africa region where Tanzania is located. So the key issue here has been around dismantling some of the structural barriers that exist within our system. And it's very important that when it comes to the actual planning for the country, it's very important to take into consideration the different geography within a countries. Because I know we can always talk of a Tanzanian culture, but when it comes to the real life, Tanzanian culture is very diverse. And therefore, the social issues are very different when you move from the north to the south, when you move to the coast to the west, as well as when you go to the central part of the country. So it's good for the country strategies to really take into consideration the local context. That is where we can expect impactful results at the end of the day. So apart from, again, I repeat, Wena and Dada Margaret has already highlighted the importance of taking in consideration the age, the location, and the risk level of a particular man population when it comes to planning to address HIV among them. And one of the most important issue is to make effective use of available data and data analysis mechanism to ensure that whatever data is being spoken about or shared within the country is as disaggregated as possible to really inform identifying the inequalities within the epidemic and identifying where exactly the male are being left, whether it's testing, whether it's when it comes to engaged and remaining treatment, whether it's around the issue of having a successful treatment kwa maana ya kwamba viral suppression imekuwa achieved. Those are very important low-hanging fruits that can actually help us tailor whatever program we have, HIV-related program that we have, to ensure that we don't leave men behind at the local epidemic context, not necessarily at the country level, because that's where we have an opportunity to unpack data, therefore, so that our actions are tailored based on the exact gaps that have been identified. Therefore, it's very important from what we are seeing. I'm just trying to put it in a way that we are all on the same page. Issues around HIV among men, the reasons for the gap are multiple. They are quite intertuned, and some of them are quite deep-rooted in the society that men live. So it's very important for us to really deep dive into the context before we plan for the intervention that we want to do to actually reach the result that we want. And that's why UNAIDS and the partners, we regularly organize a platform for sharing experiences and learning from like countries. And this is an important opportunity for the country to learn what works in other societies and therefore see how they can adapt and use in our context here. Maybe if there's another question that I did not touch, if you can remind me.
Dr. Loy uko sawa. So kwa kukazia kama tungeweza kuona effort ya complement Minister of Health kwenye Reaching Men with Prevention Package and HES. Karibu.
Asante sana. So as I said, from the guidelines that exist, one of the key work that UNAIDS and partners and the UN system have been doing really is from ensuring that the country have most up-to-date evidence-informed guidance in terms of informing the strategies and the approaches that the country is using to inform the country plans. That's a very important part of work that UNAIDS and the UN system does. And I must say, this is not done in isolation. it is done in a wider context of facilitating and providing country leadership and guidance, ensuring that the HIV response is as effective as it is. That has been an important key role that we are doing with the ministries and the government agencies that are engaged in the HIV response. And one of the most important things that currently the UN system is putting a lot of effort is ensuring that efforts to reach out men are very much well articulated in the overall HIV programming, because this is very important for the continuity and for sustainability of the HIV response. And therefore, we kind of ensure that the existing systems are kind of worked out to include men in a specific way, but not running HIV program for men as separate platform. And this is well informed in the ongoing country work to develop HIV response sustainability, whereby we are supporting the country to deep dive into the existing data, existing information, and address the existing gaps, including efforts to reach men with HIV services. And of recent again, and this is going to come as in the next few weeks, is that the CLM initiative, this is community-led monitoring, which is by PLHIV and people who are at the highest risk of HIV, we have a plan to ensure that the country has got sustainable platform for that. And therefore, we are also encouraging the country, and we are going to support the country to ensure that some of the key interventions they are going to put are meant to actually address the gaps, including the HIV gap among men. And that's a very important activity that the UN system is supporting the country. Thank you so much.
Asante sana. A round of applause, please. Dr. George, nimependa ulivyoweka msisitizo na kutuambia masuala mazima ya proper use of data, tukiamini kwamba no data, no right to speak. Now I'd like to call upon Mr. Bernard Ogwang, who is a program management, public health and development specialist with over 20 years of experience in comprehensive HIV program strategy, development, designing, implementation, monitoring, and evaluation of key and vulnerable population in East Africa. Mr. Ogwang holds masters in rural sociology, and MBA in strategic management. A round of applause to Mr. Bernard Ogwang. I'm not sure if I'm spelling it, I'm try to put it in a proper way. Is it Bernard or Bernard? Thank you so much. So, Mr. Bernard Ogwang, there are some things we'd like to know from you. If you can share the successful strategy that have effectively engaged men in HIV prevention and care, if there are some innovative approaches or technology that have shown promises in reaching men with HIV prevention, care, and treatment, and what is the poorest barrier which prevent access to HIV services to men. And kwa upendeleo, ningependa pia kama unaweza ukawa una code switch kwenye vile vitu ambavyo vinaweza vikaendana na yule panelist atakayefuata. You're warmly welcome, sir.
Thank you very much. I think I'll start by building on what I'll continue building on what the previous prof have shared. And I would like to start by saying that as a program, and I'm referring to EPIC, which is a community-based program that is implementing a range of interventions in 11 regions in Tanzania, funded by PEPFAR through USAID program. We have been implement interventions targeting several populations, including men. Last year alone, I think we were able to reach up to about 150,000 men across the 11 regions. Out of those, we had about 130,000 receiving HIV testing services. So, based on the experience that we've had in terms of implementing HIV prevention care and treatment services targeting men, one, we have learned that we need to be intentional in terms of, before implementing interventions, of answering the question is, where are the men found? And we have always been intentional. Now, to help us respond to this question, we have intentionally engaged the men themselves in helping us respond to these questions because we realize that they are the best source of information in terms of where we can find men. So traditionally, what we realize that works before we provide services, we go out in the communities, we map out sections where there are hangouts, joints, places where men are found. We have discussions and engagements with them, try to understand who they are, what they do, why they do what they do, and collect that information and use it to design interventions that target men in those communities through a process that we call micro-planning. So micro-planning helps us to identify where the men are, what time we can be able to reach them, how we need to reach them with services. And through that, we also realize that men are not a homogeneous population, rather they're heterogeneous. So we tailor services based on, for example, age categorizations, because we realize that the needs of men 15 to 19 are not exactly the same as those to 20 to 24, and even beyond those who are over 25 years. So the first thing that we've realized that works is answering the question, where are the men? And to answer that question, we've found out that ni vizuri kuwahusisha wanaume wenyewe kwenye huu mchakato ili kuhakikisha kwamba tunafahamu ni sehemu zipi ambazo tunaweza kuwapata through the process of micro planning. The other thing that we've learned is engaging the men themselves in designing our programs, not just as service users, but planning with them. So before we decide where we want to reach the services, we have always been intentional ili kuhakikisha kwamba tunawahusisha kwenye ubunifu, utekelezaji, and even evaluation of those programs themselves at those different levels. So that way, we are sure that we are building on their experiences. And through that, we've been able to collect information that helps us understand where we can reach them with services. So we know if we want to reach out to fisher folk, we know where we find them. If we want to reach out to borders, tunafahamu sehemu ambazo tunaweza wapata. If we want to reach out to men in tournaments, then we're able to reach out them in those populations. So microplanning has been very important. We've also learned that using the men themselves to reach out to other men is a very effective strategy. So we have cohorts of what we call peer mobilizers and peer education. So we do a peer education, or rather outreach-based approach, where we engage peer educators who are then able to reach out to their fellow men, identify where we are, and then work with the Ministry of Health to ensure that they are providing the comprehensive packages of services. So that is one thing, the other thing that we thought that we have realized that works. Of course, all this, the other third thing I think has been discussed by George, which is around use of data to inform our programs. We try to be as targeted as possible. And so every time we reach out to men, we are able to analyze our data and figure out what is working, what is not working. And then we are, of course, adopting what we are currently calling a fail-fast approach. If we realize that, for example, we had planned for day outreach in a particular place and you're not getting the kind of men or the results that we would desire, we quickly switch to another modality, which could be like a moonlight approach. So providing a differentiated package of services that are tailored to meet the specific needs of men, in our view and from our experience, is one of those interventions that has worked. Of course, we have noticed through our experience that there are men like entertainment, for example. So we have been able to map out several entertainment spots including sports and all the other recreational activities. So what we've tried to do is to integrate recreational activities for example, particularly for the younger men, so that we use then entertainment to mobilize them to create demand for those services and then provide them the comprehensive packages of services. Of course, we have also, for example, more recently been finding men through sports tournaments. Most of you might know what Ndondo Cups are. Some of you might have been participating in those competitions or league competitions, which an opportunity where men come together, and we have been able to ensure that we are providing comprehensive packages of services through those Ndondo Cups and any other league competitions that have been going on in other communities. So I think that has ensured that we're able to reach out to men when they are available, because sometimes we design programs and anticipate that we'll be able to reach out to them at times that they may not be available. So we miss out on that opportunity. So we have been using soccer tournaments targeting particular adolescent boys, young men, to be able to expand access and utilization of HIV prevention, care and treatment services. Of course, the other thing that we've learned that works is providing comprehensive packages of services, trying as much as possible to ensure that we are a one-stop shop, so that we're not just providing HIV testing services, but also integrating STI prevention and treatment. We're integrating other services such as PrEP for those who are HIV negative during our outreach programs. So this way, they get excited and it becomes one of the ways and then in which you're able to provide those services. So that then, because as was mentioned, I think by George a little earlier, is that the needs of men are much more complicated than HIV services, and it is important for us to ensure that we are addressing not just the HIV specific needs, but also the other social, cultural, economic needs. And we have structural interventions that also that address all these gender norm, social, cultural issues out there. The other thing I wanted to mention around in terms of how we reach men is to ensure that we are designing services that are male-friendly as much as possible, because most of, not unless the men feel like the services are male-friendly, then they are likely not to come for those services. So I've been working with the ministry who are represented here very well, and other stakeholders to ensure that, for example, we are training healthcare providers on provision of male-friendly services. And of course, the definition of what male-friendly is one of those that we have been working closely with the men themselves to ensure that they help us understand what really works for them, how they want to receive the services, and how do you address issues of stigma and discrimination, which is part of the challenges that men experience when they are out there. Of course, the other thing that works is outreach programs. So they say that if the mountain can't come to you, you need to go to the mountain. So we have a comprehensive outreach program. And the outreach program is differentiated based on the specific needs of the men themselves. So there are men who we are likely to find during the day. So for those ones, we provide day outreaches. There are men who you are likely to find in entertainment joints at night. So we provide moonlight outreaches. But we also have a mobile clinic a mobile van that goes around. So before that, usually there's an advanced team that goes, does the mapping, identify which will be the best place, does demand creation, community engagement, and ensure that the men are prepared to receive those comprehensive packages of services when they come to those sessions. And finally, I also wanted to say that what else that works for men is basically ensuring is use of technology. We all know we live in a world that is fully globalized and that is powered by technology. So what we have done is to map out different social media platforms where we engage them. One of which that we have, for example, is what we call Jicheki Ora, which is an online reservation platform which allows young men, men in general, to book appointments online, and then we're able to link them through those platforms to healthcare providers who have been trained on utilization of those services. And we've realized that that has ensured that we are breaking into networks, particularly around men who may have digital media in their hands, but then they are able they are not utilizing it. So we've realized that optimization of digital platforms, leveraging on digital platforms, such as Jicheki online platform that I've mentioned, actually helps us to expand access, create demand, expand access, and utilization of comprehensive HIV prevention care and treatment services. So one of the other questions that I think you asked was around some of the policy barriers, right?
Yes.
Yeah, around that prevent services. Well, my previous presenters talked about the existing frameworks, and they have provided guidance around that. We still feel that there are some barriers. So for example, if I talk about pre-exposure prophylaxis, while we have been intentional in trying to expand PrEP access for men, we still feel that there are challenges because the current framework doesn't allow us to be able to provide PrEP services to the men in the way that we desire to. Of course, we continue engaging closely with the NASHCOP and TACAIDS to ensure that we are, and there are plans in place to ensure that the framework is reviewed, and we hope that that process can be fast-tracked to ensure that we provide PrEP services to the men particularly who desire it. So that is one of the policy barriers that I think that we have. Of course, generally, even though there are few policies and guidelines targeting men, you'll agree with me that most of the policies that have been developed around sexual reproductive health largely target women. And so we hope that we are likely to see more and more policies that will create an enabling environment where men can be able to access services beyond just what we have. Of course, we also know that sometimes we have many female-specific services or women-specific services. Rarely do we find male-specific services. So maybe having frameworks and guidelines that would help us exponentially expand male clinics, for example, and also ensure that the package of interventions that is being implemented are those that are male-specific. Are some of those, if we have policies that are around that, then they would also help us to substantially expand access and utilization of HIV prevention care and treatment services targeting men. Thank you.
A round of applause to Mr. Bernard Ugwang. Asante sana Mr. Bernard. Nimefurahi ambavyo mmeamua kuifanya technology kama fursa, since most of men wapo kwenye social media na vitu kama hivyo. So I think this is going to be a very good approach, and probably inaweza ikachukuliwa kama innovation kwa watu wengine na ikasaidia. So kwa wale wenye maswali nasisitiza tuendelee kuyaweka chini. Tunakuja kwa panelists wetu wa mwisho. Baada ya hapo tutakuwa tuna maswali 5, halafu tutaendelea. Panelist wetu wa mwisho anaitwa Edie Swed. Edie Swed, 21 years, born in Wami Dakawa Village, Mvomero District, mkoani Morogoro. Anafanya kazi kama music librarian and is a passionate peer educator under the EPIC project. Edie plays a vital role in mobilizing adolescents and young men to access and demand HIV services.
Asante.
His unique approach of incorporating music and singing while leading HIV session effectively engages participants and enhances their learning experience. Edie amekuwa ni kijana mwenye kipaji sana cha kufanya mobilization, hasa kwa kutumia music and dances na kuweza kuwafikia vijana pale walipo, na ni kazi ambayo amekuwa akiipenda na amekuwa akimobilize na kuwafikia vijana wenzake na wanaume mbalimbali kwenye maeneo ya Mvomero Dakawa mkoani Morogoro. Edie kama mmoja wa watoa huduma kwenye ngazi ya jamii, nitaomba tuzungumze vyema kwa Kiswahili, nikiamini kwa wale ambao hawatakuwa na uelewa kidogo wa Kiswahili basi watu kwenye flow wanaweza kusaidia for translation. Edie, tafadhali unaweza kutuambia njia gani ambazo unazitumia kuweza kuwafikia wanaume kwenye eneo lako la kazi?
Asante MC. Kwanza awali ya yote ningependa kutoa shukrani zangu za dhati kwa MC, Mwenyezi Mungu na viongozi wote mnaonisikiza ambao mpo humu ndani. Wakubwa shikamoni. Asalamu alaykum.
Alaykum salam.
Bwana Yesu asifiwe.
Amen.
Kristo tumaini letu. Asante. Mimi kwa majina naitwa Idi Juma Swedi, ni mwelimisha rika, natokea kata ya Dakawa iliyoko wilayani Mvomero mkoani Morogoro. Sasa kutokana na kazi ambayo mimi nafanya, zipo njia ambazo zinanipelekea mimi kuwapata wanaume kwa ajili ya kuwapa elimu. Njia hizo ni mbili, ambapo njia ya kwanza ni njia ya kuwafikia wakiwa katika makundi, na njia ya pili ni njia ambayo nawafikia kwa mwanaume mmoja mmoja. Ila sasa kabla ya kutambua hizi njia ambazo mimi nazitumia kuwafikia wanaume moja kwa moja, kwanza inabidi utambue kwamba kabla sijawafikia, je, ni maeneo gani ambayo naweza nikawapata au wanaume? Sasa nikisema ni maeneo gani, naweza nikaeleza tukianzia kwenye njia ya makundi. Je, ni maeneo gani ambayo naweza nikawapata? Na ukiachilia mbali eneo ambalo naweza nikawapata, je, ni muda gani ambao naweza nikawapata na nikawapa elimu ya afya mpaka kufikia kwenda kupata huduma? Moja, wanaume kama wanaume katika njia ya makundi naweza nikawapata kwenye vijio vya bodaboda, sawa, vijio vya kucheza pool table, vijio vya kucheza draft, na vijio mfano wale wacheza mpira, vijana wa mazoezi. Ina maana kabla sijatambua vijio, lazima nijue kwanza hao wacheza pool table naweza nikapata muda gani kuongea nao. Muda gani wanakuwa hapo wengi sana kijiweni kwao? Hao wanaocheza mpira, wana mazoezi, muda gani ambao wanakuwa hapo kwa wingi zaidi? Na hao wanaocheza draft, muda gani ambao naweza nikawapata kwa wingi zaidi? Kwa ukishajua sasa muda huo, ndio unaweza ukatenga muda wako wewe kwamba muda huu ambao nimejua hao ndio watakuwa wengi zaidi. Ina maana ndio utakaa nao chini kwa kuelekeza, jamani, siku fulani tutakuwa na tukio fulani, kutokana na muda wao ambao wao wanaenda kufanya jambo. Ukitaka uwapangie muda, kikweli utafeli, kwa sababu ataona sasa kama unawapangia. Wewe angalia muda wao kwamba pool table sana sana kwa sasa hivi wanaanza kuwepo kuanzia saa 9, kwa sababu umepigwa marufuku muda fulani, kwa maana kuanzia saa 9 ndo ataanza kuwepo, sawa. Hawa wacheza draft, sawa, hawa wanaanza kuanzia saa 5 mpaka jioni, kwa maana kumbe saa 5 mpaka jioni naweza nikawapata. Ila bodaboda kuna muda wao maalum ambao nawapata, nitazungumza nao kuhusiana na masuala ya afya na mpaka kufikia kwenda kupata huduma. Lakini je, nawezaje nikamfikia mwanaume mmoja mmoja kwa ajili ya kumpa elimu akanielewa mpaka akafikia kwenda kupata huduma? Zipo njia kama 3 au 4 za kumfikia mwanaume kwa mmoja mmoja. Ya kwanza, unaweza ukamfuata katika sehemu yake ya kufanyia kazi. Nikisema sehemu yake ya kufanyia kazi, mfano kuna baadhi ya wanaume ambao wanauza magenge, tunaelewa. Unaweza ukamfuata gengeni pale, yuko peke yake, unaweza ukaenda ukampa elimu ya afya na ukamshawishi pia kwenda kupata huduma ya upimaji na kadhalika. Lakini sasa ukiachia hili swala la kumfuata mmoja mmoja katika eneo lake ambao yeye anafanya kazi, bado unaweza ukamfuata tena huyo mmoja, au yeye akakufuata mwenyewe. Anakufuateje? Ipo hivi, wakati unatoa elimu kwa wanaume kwa njia ya makundi, sawa, sio wote ambao wanaweza wakauliza maswali na sio wote wanaojiamini kuongea kila kitu mbele ya wenzao. Wengine unaweza ukawapa elimu ya afya, mwingine akawa na uoga kwamba hapa kweli na mimi niulize swali mbele ya fulani yupo, mimi nitaonekanaje? Anaweza akanyamaza. Hiyo moja. Lakini ya pili, mwingine anaweza akasema hapa kweli mimi niulize swali hapa kweli, na maana huyo sasa ana aibu. Lakini wewe kama mwelimisha rika, wakati unatoa elimu ya afya, hauwezi ukaondoka pasipo kuacha mawasiliano yako kwa wale unaowapa elimu. Wote lazima wape mawasiliano yako na jina lako, kwa sababu kuna wale wengine hawawezi wakasema privacy zao pale. Anaweza mtu akakupigia akakuelekeza. Kwa hiyo sasa ukishaachia namba, mwingine anaweza akakufuata yeye kama yeye akakwambia, bwana ndugu yangu, pale mimi nilishindwa kuongea kitu fulani, lakini bwana swali langu mimi kuhusiana na masuala ya afya ni 1, 2, 3. Kwa hiyo sasa njia ambazo sisi tunazitumia kuwafikia wanaume kwa ajili ya kuwapa elimu ya afya mpaka kufikia kwenda kupata huduma ni njia 2. Tusisahau, ni njia ya makundi na njia ya mmoja mmoja. Asante MC.
Asante sana. Another big round of applause. Tunajua kwenye jamii zetu tunazofanya nazo kazi, hatufanyi tu kazi, lakini tunashirikiana katika kufikia kile ambacho tunakifikia. Tunatamani kujua wadau katika jamii yako wanashirikishwaje na kama kuna mchango wote ambao wanautoa kwenye kile ambacho unakifanya. Karibu Idi.
Asante tena MC. Kutokana na kazi yangu naoifanya ya uelimishaji rika, sawa, siko peke yangu. Katika jamii ambayo mimi nafanya kazi, nina wadau mbalimbali ambao tunashirikishana katika swala zima la kuwaelekeza wanaume kuhusiana na masuala ya afya na mpaka kwenda kupata huduma. Baadhi ya wadau ni mwenyekiti wa kijiji, mwingine anaweza kaa ni mtendaji wa kata, sawa. Je, mimi kama mimi sasa mwelimisha rika na washirikishaji hawa, kabla sijaanza kufanya kazi ya uelimishaji rika, naweza nikaenda kwenye ngazi za serikali kama hizi nilizozitaja hapa, kwamba ni mwenyekiti wa kijiji, mwenyekiti wa mtaa. Naweza nikamfuata nikamwelekeza kwamba mimi naitwa fulani, kazi yangu mimi ni fulani na nipo hapa kwa ajili ya kufanya jambo fulani. Sasa unapomwelekeza yule mwenyekiti ambaye yupo serikalini, ambao unamwelekeza kwamba wewe unatakiwa kufanya 1 2 3, sawa, hii inakusaidia wewe mwenyewe, sio kwamba unamwelekeza alafu basi, hapana. Unapomfuata kwa sababu yeye yupo ngazi ya serikali, ukamwelekeza kwamba wewe unafanya nini katika jamii, bado upo msaada ambao yeye anaweza akakupatia wewe. Je, ni msaada upi? Huu hapa. Moja, kwa sababu yeye ni mtu wa serikali tayari kama nilivyokwisha kusema hapo mwanzo, sawa. Kwa hiyo ina maana anakutana mara nyingi sana na mlundikano wa vijana. Anakutana na vijana katika makundi mbalimbali, aidha katika mikutano ya vijiji, katika shughuli mbalimbali za jamii. Kwa hiyo ina maana wewe utakapomshirikisha, hata wewe kwako itakuwa rahisi sana kupata vijana. Anaweza yeye akakusaidia kuwapa elimu, sawa, ambayo wewe umempa yeye kidogo, kwa sababu hauwezi ukaenda kumshirikisha tu afu kaambia kesho kutwa nitakuwa na vijana, alafu usimwambie vijana watazungumza nao nini. Sawa? Lazima umwambie kwamba kesho kutwa nitakuwa na vijana, lakini nitakapokuwa nao vijana, mada ambazo tutazungumza ni 1 2 3. Ina maana sasa ukishamwambia hivyo, yeye anao uwezo wa kukutana na vijana na akawaelekeza na akawapa elimu kidogo, ila sasa akasaidia tena vile vile wewe kukukusanyia wale vijana kwamba jamani, kuna kijana mwenzenu mnamfahamu anaitwa fulani fulani fulani, anafanya kazi katika asasi fulani, lakini hapa ametoa wito kwa vijana wenzake ambao ndio nyie, siku fulani atakuwa ana jambo ambalo anataka kuzungumza na nyie, sawa. Aidha yule kiongozi wa serikali ambaye ni mwenyekiti wa mtaa mfano, siku hiyo na yeye akawepo au asiwepo, ila moja au nyingine kakusaidia kuwakusanya wale vijana, ili mradi wewe utoe elimu ya afya na mpaka kuwashawishi kwenda kucheki afya zao na kupata huduma. Hilo moja. La pili, upi mchango wao katika jamii ambayo mimi nafanya kazi ya uelimishaji rika? Nitakapowashirikisha viongozi mbalimbali kutoka kwenye serikali, upo uwezekano kwa sababu wale ni viongozi, sawa, tunafahamu serikalini huwa zinatokea fursa mbalimbali. Sasa yule mwenyekiti au yule kiongozi wa serikali ambao mimi nimemshirikisha, atakapokuwa anatambua uwepo wa vijana ambao mimi nafanya nao kazi na wapa maelekezo kwamba kuna swala la kucheki afya, au anajua kwa kama mara kwa mara huwa tunakutana, hata kama kuna fursa fulani ambayo inatokea serikalini, inakuwa ni rahisi sana ile fursa kuihamishia kwa wale vijana, yani kuwasogeza katika fursa ile, kuisogeza katika wale vijana ambao mimi ndo nilimpa maelekezo yao. Kwa hiyo ina maana huo ni mchango mkubwa sana ambao viongozi wa serikali ambao ndo wadau pia wanaotoa kwa mimi mwelimisha rika katika jamii. Asante MC.
Asante sana. Thank you so much. Kutokana na swala la muda, ningependa kujua vitu viwili vya muhimu kabla tujakaribisha maswali kutoka kwenye washiriki waliopo huko chini. Tunatamani kujua changamoto unazopitia mara kwa mara wakati unatoa huduma zako, hata walau changamoto 2, lakini pia unafikiri nini zaidi kinatakiwa kifanyike au ungependa kifanyike ili kuweza kuwafikia wanaume katika jamii. Karibu.
Asante tena MC. Hapo kidogo umenigusa, kwa hiyo naweza nikasema asante ya pili. Asante sana MC. Changamoto sio chache, ila kwa sababu umesema 2 ni sawa. Katika kazi ya uelimisharika changamoto zipo. Sawa? Utakuta wewe mwelimisharika unakutana na vijana kwa ajili ya kuwapa elimu ya afya. Sawa? Wanakuelewa vizuri, tena vizuri sana. Lakini sasa ukifika kwenye swala la kwenda kupima, kwenda kujua afya zao, sawa, hapo kidogo uitikio unakuwa mchache sana, kwa sababu bado kuna watu ambao wao akilini mwao bado na mambo ya kimila. Mfano, wanaume umeelekeza, umewapa elimu ya afya na wamekusapoti vizuri sana, mpaka mkashauriana kwamba sasa kesho tunaingia kwenye swala zima la kupima. Sawa? Unamkuta fulani yeye hayupo kabisa kwenye swala la kupima, lakini kwenye kusapoti kwamba kesho tunapima, yeye alikuwa ndo anakuunga mkono, ndo wa kwanza. Ukimuuliza, sasa mbona wewe sikuoni kwa unaenda kupima afya inakuaje? Anaweza akakujibu hivi, akakwambia, ndugu yangu hilo swala halina shida. Mimi bwana, mpenzi wangu mbona kapima yupo fresh. Kwa hiyo ina maana sasa mimi nenda ngapime tena ya nini? Yaani kama yeye yuko fresh, mimi sina shaka hapo. Ina maana mimi mwenyewe nipo good tu. Hilo la kwanza. Changamoto ya pili ni changamoto ya kimuonekano. Hili nalisema kwa sababu limeshanitokea mimi hapa, ndio maana nalisema. Unaweza ukawa unaenda kuwapa elimu vijana, sawa? Lakini muonekano wako wewe sasa ukishajulikana kwamba huyu anaenda kuwapa vijana elimu ya afya. Tena sio afya tu, yanayohusiana na masuala ya ukimwi. Sawa? Kuna baadhi yao watakwambia kwamba yule tayari, yani ukimwona yote anaenda kutoa masuala ya afya, ujue yeye kashaasilika, ndio maana anaenda kuwapa na wenzie ili wafuate stake zero na wao wasiasilike. Sawa? Kwa hiyo kitu mimi nimekumbana nayo live, yani kabisa watu wakawa wanajua kwamba mimi nimeasilika. Yani huo ndo ukweli. Kwamba fulani anaenda kutoa elimu ya afya kwa sababu na yeye ameasilika. Hilo tuachane nalo. Alisema 2. Asante sana MC.
Asante.
Swali la mwisho uliulizaje? Kuna swali la mwisho.
Nini kifanyike ili kuweza kufikia wanaume zaidi kwenye jamii zetu?
Safi sana. Mimi ushauri wangu, sawa? Ushauri huu sana ningependa ni bezi kwa wanaume. Sisi wanaume. Kwanza wanaume mpo? Safi. Wanaume, ushauri wangu mimi, sawa? Tusijiogope. Twende tukacheki afya. Twende tukapime ukimwi, kwa sababu hasari ya wewe kutokwenda kupima ukimwi au ukienda kupima ukimwi, sawa, ukakutwa kwamba ukimwi unao, sio mwisho wa maisha. Huo ndo ukweli. Hilo la kwanza. Halafu la pili, yatakwenda ukacheki afya yako, ili mradi ukishajijua kwamba mimi nina maambukizi, sawa, ziko step ambazo utapewa. Ushajulikana kwamba MC hapa na maambukizi, mfano samanini, ushajijua kwamba
it's okay.
Sawa. Ushajijua kwamba mimi nina maambukizi, sawa? Mtoa huduma atakapojua kwamba una maambukizi, moja kwa moja aweze akakwambia tu kwamba bwana, wewe tayari tushakupima, tayari tushakujua kwamba una ukimwi, wewe nyumbani ukalale. Hapana. Yeye kama mtoa huduma, sawa, atakuunganisha wewe kwa ajili ya kupata huduma tiba na matunzo. Lakini vile vile ukiwa hauna ukimwi, sasa yani hujapata maambukizi ya virusi vya ukimwi, lazima kuna ushauri ambao utakaopewa, aidha kutumia kondomu kwa ajili ya kuepukana na magonjwa ya ngono, kuepukana na virusi vya ukimwi, pia kutopata mimba zisizotarajiwa. Lakini vile vile ninachoshauri kingine, wanaume ndio akapime, kwa sababu usipopima, sawa, unaweza ukawa unaishi na virusi vya ukimwi katika mwili wako, na pasipo kujua afya yako unaweza ukaenda ukawaumiza wengine ambao hawana hata hatia, kwa sababu unaweza ukawa hujui afya yako na ukawa na ukimwi. Alafu kingine zaidi, unapofanya tendo wewe upendi hata kidogo kutumia kondom. Kwa hiyo ina maana kama wewe una maambukizi ya virusi vya ukimwi, halafu unapofanya tendo pia haupendi kutumia kondom, ni lazima waumize wengine.
Asante sana. Makofi mengi kwa Idi Swedi kwa kile alichoshare. Sema tu rafiki yangu, umetoa siri yangu. Tutaongea baadaye.
Samani.
Asante sana. Tunakaribisha maswali 5 kutoka kwenye flow, na maswali haya yatakuwa ya upendeleo na tunaomba tuyajibu kwa ufupi ili iweze kusaidia. Tuko karibu na muda. Asante.
Asante. Maana yebi kuna faida ya kuvaa tai wa dada. Asante presenters kwa presentation nzuri. Nafikiri naweza kuuliza Kiswahili ama kwa Kiingereza. Nitauliza haraka haraka. Nina maswali matatu. Swali la kwanza nitaanza na Dr. Wena. Aliongea kuhusu female are more likely to use condoms than male according to hiyo. Ningependa kuelewa vizuri zaidi kwa sababu tunafikiri kwamba labda wanaume ndio wanatumia zaidi condom, na kama ni wanawake ndio wanaripotiwa kutumia zaidi condom, ni condom zipi tunaziongelea? Tunaziongelea condom za kike ama tunaziongelea kwamba wanawake wanatumia condom za kiume? Ningeomba ufafanuzi. Lakini nina swali pia kwa George Loy, ili jina lanifanya niulize kwa Kiingereza. Mr. George Loy, you talked about complementing the impact of women, of men, kwa sababu umesema iko intertwining kwenye ku bring men on board. Sasa what is currently happening is that the implementation ya program nyingi zinazofanyika kwa wanawake kama ulivyosema na vijana zimesababisha kuwatenga wanaume. Are we not going to do the same if we only talk about men? Kwa mfano kuna watu walifanya study wakaona kwamba kwa mfano kama VMMC ili wanaume waweze kupata tohara walikuwa wanapitia kwa wanawake. Mwanamke akikataa mkono wa sweta, show nadhani inaeleweka. Kwa hiyo inakuwa inasababisha mwanaume aone kuna umuhimu wa kufanya tohara. Je, unafikiri kuna umuhimu wa kufanya hivyo ili tena tusije tukafika tena mbele tukaanza tena kurudi nyuma? Alafu pia uliongelea kuna call to actions za framework ambazo ziko meant kwenye ku accelerate ambazo zimeanza 2020. Can you give us example of one? Na la mwisho ni kwa Mr. Bernard. Na Mr. Bernard aliongelea microplanning, ambao kwenye hii microplanning nilingependa kujua how is this different from the normal hotspot mapping that we already do kwenye community level wakati wa implementations ya kazi. Lakini pia uliongelea there is a way that one would wish or the desire ya ku provide prep for men, lakini we never said what is this desired way ambao tungefikiria kwamba ingekuwa ni nzuri zaidi kwa wanaume za kugawia prep. Thank you very much.
Asante sana. 2 more questions and then
moderator, naomba uniongoze niweke mic wapi, maana naweza kuwa niko biased.
Sawa. Kwa mdau alafu utatoa kwa
Okay, good afternoon. Naitwa George Mgomela. Nitakuwa na maswali mawili, moja langu binafsi, lakini la kwanza ambalo nitalielekeza kwa Edie Swed nitakuwa Thanks Alice. Nitakuwa na lielekeza kwa Edie Swed kwa niaba ya Jessica Green, PEFA Coordinator Tanzania, ambaye amesema kwamba amefurahi sana kusikia hiyo mipango mikakati yote ambayo serikali na partners mmekuwa mkiongea hapa, lakini anasema je, tujiulize hii mikakati pamoja na hizi interventions na approaches tumekuwa tukifanya hivyo kwa miaka 10 iliyopita. Swali hili tena kwa Swedi, je, kitu gani ambacho wadau na mipango mikakati ya serikali ya kupata wanaume tumekuwa tunafanya wrong? Ambao kwa kweli hii ni kwa ushahidi kabisa, ukiangalia kwenye matokeo ya takwimu za THS 2016, 2017 na 2022-2023 bado tuna changamoto pamoja na mikakati yetu mizuri. Je, yeye kama mdau na anaamini kwamba anawakilisha wanaume, je, tufanye nini na kuna mipango gani ya innovation ya kuweza kufanya? Na kwa upande wangu mimi nimefurahi sana kwa Edie Swed kuwepo hapo, na swali langu kubwa kwa sisi wote, Edie ni mwanaume, wanaume wewe, lakini wanaume sio homogeneous group. Kuna wanaume vijana, kuna wanaume wasiofanya kazi, kuna wanaume wanaenda shule, kuna wanaume ambao wanafanya kazi. Sasa tunapokuwa tunaongelea swala la wanaume, naona kama tunaongelea kama ni homogeneous group. Tufanye kitu gani tuweze kujua makundi tofauti na tunaweza kuyapata? Kwa kumalizia comment, hata wanawake hatukuwa na mipango mkakati ya makusudi ya kupata wanawake. Tuliwapata kwa bahati mbaya, kwa sababu wanawake wengi wamekuwa kienda kwenye hizo huduma tu kama sehemu ya afya ya uzazi, yani pregnant related antenatal care, PMCT, na hatuna kitu mbadala kama hicho kwa wanaume. So nadhani pamoja na kujipongeza kwa ajili ya wanawake, tufikirie pia kuna kitu gani ambacho tunaweza tukafanya kwa wanaume Je, tukiunganisha na non-communicable diseases, tukiunganisha na other traditional activities, how can we get men and link them to care? Kwa sababu wanawake tunapata kwa bahati mbaya zaidi. Asante.
Thank you so much. We are going to be very brief tujibu hii maswali, and then baada ya hapa kuna wenzetu wanaendelea na session, kwa tutakuwa tuna side meeting pembeni kwa ajili ya clarification kwa maswali mengine. Karibuni.
Asante. Ningependa kujibu swali la 3 kuhusu matumizi ya condom. First of all, we have to understand that the most common type of condom we have is male condom. That's one. And this question is set in such a way that it just asks, did you use condom during the last sexual intercourse? Yes or no? So whatever is being seen here probably could require further scrutiny, probably through qualitative research. That's my take. Because this is very subjective and we know how people respond to such sensitive questions. Thank you.
Yeah, thank you. You can proceed in 1 minute.
Swali langu lilikuwa microplanning na how is it different from hotspot mapping? Hotspot mapping ni part of microplanning. So hotspot mapping ni kumap tu hotspots, lakini kuna kitu tunaita for example hotspot analysis. Unataka kujua wanaume akina gani wako pale, age differences zao. Je, kuna violence ambayo ina happen pale? Wana access services gani? STI, kuna prevalence of STI na mambo kama hayo. So hotspot mapping is basically much more broader. Na hotspot mapping ni moja wapo ya vipengee vya hotspot mapping ambayo tunafanya. Swali la pili lilikuwa kuhusu PrEP. PrEP bari ambayo nilizungumzia ilikuwa ni kuhusu guidelines ambazo zipo sasa hivi. Tuko na PrEP framework ambayo inaturuhusu ku provide PrEP services kwa makundi fulani. Lakini kuna makundi fulani ya wanaume ambao kidogo bado inahitaji review ya PrEP framework ili kuhakikisha kwamba hao wanaume wengine ambao hao kwenye groups zile ambazo zimetajwa pale wanapata nafasi ya kupata PrEP services. Hapo nimejibu.
Jamani, tuna roll out microplanning nchi nzima. So I better you differentiate between spotting na microplanning. So inakuwa rolled out nzima, strategy iko tayari.
Asante sana. Thank you kwa swali lako. Quick response. Moja, issue ya kuanza kufanya vitu kwa ajili ya kuaddress HIV kwa wanaume ni tutumie opportunity kwa success na approaches ambazo zinatumika kuwafikia wakina mama na wadada wadogo. Hiyo tutumie katika kuaddress gap ambayo tunaiona kwa wanaume, ili tusifikie wakati ambapo tuna address ukimwi kwa wakina wanawake na wasichana, tunasahau wanaume ambao ni sehemu ya hao wanawake, ni sehemu ya familia. Kwa sababu tukifika mbali sana tunaanza kurudi nyuma, tutakuwa tumechelewa. Kwa hiyo mapema sasa hivi tuanze kutumia platform ambazo zipo, tuanze kufanya vitu ambavyo they really address the special need ya wanaume. Kuhusu call to action, kuna framework ambayo imetolewa kwa ajili ya kusaidia nchi na partner wote kwa ujumla namna gani ya kuanza kufanya assessment na kuona gaps zilizopo na kuaddress kwa kuinnovate na kuscale up interventions ambazo zimeonekana zinafanya kazi katika nchi mbalimbali za Afrika, particularly chini ya jangwa la Sahara. Asante.
Asante sana. Makofi tafadhali. Najua tuna maswali mengi na tungependa kuendelea, lakini kwa sababu ukumbi unakuja kutumika kwa session inayofuata, kwa hiyo naomba tuweze kujibiana maswali yetu hapo pembeni. Najua kuna maswali hayajajibiwa bado. So tutaomba tupate picha ya pamoja kabla mjashuka wakati wenzetu wanaendelea kuset microphone. Thank you so much ladies and gentlemen and have a good evening.